So let me begin by expressing my gratitude for that very kind introduction. I hate introductions. And I think the reason is because your expectations are now really high. And it's a bit daunting. But I've addressed you, I think, twice before in recent years. And I've been honored and delighted both times. And this time I thought I would try something a bit different. So in the past, I've talked about my research and my research interests. But I was actually interested this time in talking about teaching and even just to sort of walk through the process in which I developed a course, and it's a course about death. And then in the second half, after the break, talk about public health and share with you what I regard as really terrific news, that we have a new major at Willamette University called Public Health, and that I'm part of it, so I'm very excited about that. So I thought I would share some of that excitement with you. So many, many, many years ago, when I was still a very new and junior faculty member, I started asking my colleagues about whether or not we could and should be talking about death and mortality. And pretty uniformly, the reaction from my colleagues was sort of nervousness, and they would turn and sort of walk in a different direction. There's a lot of discomfort around this topic, and perversely, I knew then that I had to teach a course on death, and not flinch from putting death in the title. And it took me a couple of years, but I've taught now for about 18 years. A course entitled Death in America. So that's what I want to talk about in this sort of first chunk, and hopefully I can get through everything I have in mind and still have some decent time for questions. I'm not going to use a PowerPoint. I'm going to try to use a PDF, which is a bit different for me, but we'll see how this goes. So I've updated the title a tiny bit, and I'm going to take these in reverse order. So I'm going to take them in the order I have them in. I'm going to talk first about mortality and second about public health. So if I was interested in teaching a course on death, how would I go about sort of beginning this? My training is partly in philosophy, as it turns out. So the place that it seemed to me logical to begin was with the sort of the great classic source and font of philosophical wisdom. So here's my question: why and how to teach a course on death in America? And the big philosophical topics are mortality and finitude. There's a way in which we can ask of philosophy, what can we learn about mortality and finitude? And my great source from which I want to begin is Calvin and Hobbes. So this is going to be hard for you to read. Here's the exchange they're having. Calvin, live for the moment is my motto. Still Calvin. You never know how long you've got. You could step into the road tomorrow and wham, you get hit by a cement truck. Then you'd be sorry you put off your pleasures. That's why I say, live for the moment. What's your motto? So now he's asking the tiger. The tiger says, look down the road. So I think this is actually quite profound because it does register two very different philosophical sort of positions or relationships towards the awareness of finitude, which is, on the one hand, presentism, be in the moment, be present, realize how sort of fleeting life is. And the other, the tiger's position is one of planning, preparation, and precaution. Right, sort of plan for the future and sort of dole out pleasures. Think about your life as a series of increments. Here's a second piece of insight, again, from Calvin and Hobbes. And again, let me share with you what the actual exchange is. This is Calvin now being a lot more philosophical. Let's say life is this square of the sidewalk. We're born at this crack and we die at that crack. Now we find ourselves somewhere inside the square and in the process of walking out of it. Suddenly we realize our time here is fleeting. Is our quick experience here pointless? Does anything we say or do in here really matter? Have we done anything important? Have we been happy? Have we made the most of these precious few footsteps? And what's so striking then is that the cartoon ends with the two of them stuck and it's now nighttime. In other words, those questions have so overwhelmed them. And so it turns out that, you can be presentist, you can be precautionary, but you can also, if you will, procrastinate and experience a kind of paralysis. That is, the knowledge of your finitude can prove overwhelming. So if I think about philosophers who have had a lot to say about mortality, this would be sort of high on my list. This is Michel Montaigne, the inventor of the essay as a kind of, practice of thinking, process of thinking. And he actually has an essay, chapter 19 in book 1, entitled that to study philosophy is to learn to die. And here's the sort of thing that he says, and I think this is sort of packed with meaning, and one could, in a course, spend a lot of time looking at philosophers talking about death. To begin depriving death of its greatest advantage over us, let us adopt a way clean contrary to that common one. Let us deprive death of its strangeness. Let us frequent it. Let us get used to it. Let us have nothing more in mind than death. We do not know where death awaits us, so let us wait for it everywhere. Now, I don't think he means by that you sort of, with a sort of heavy heart, suspect a cement truck coming at you from any direction at any moment, but that you become comfortable with the idea that you're finite. Right? I think that's really where he wants to go. And that there's a certain kind of freedom that comes from getting used to that idea. To practice death is to practice freedom. A man who has learned how to die has unlearned how to be a slave. So that's a philosopher. Montaigne, though, it must be said, is really thinking about mortality as an individual might encounter the experience of it. But we can turn to cultural historians. And so a particularly prominent and influential one is this fellow, Philippe Herries, who's a sort of historian of childhood and family, and also, as it turns out, mortality. Writing originally in French, these are the translated books, The Hour of Our Death and Western Attitudes Toward Death, and a book with a lot of pictures, images of man and death. And what he does as a cultural historian is suggest that how we think about death, or how a society or a culture thinks about death, really impacts what one thinks the purpose of politics is, in terms of regulating death and how we share death and make it public, make it an event that we all experience. It is connected to assumptions about nature and metaphysics, obviously religion and the afterlife for most of sort of the history of Western civilization, and also ethics, and in particular, if you will, death as the embodiment of a certain kind of monstrous evil. And it leads him to, offer a kind of periodicity of Western cultural attitudes towards death. So one could, as a teacher course, go down this sort of road and, if you will, fill in these cells at some length and sort of think about how death has a kind of cultural history. And the individual experience, in the way that Montaigne wants to think about it, it needs to be located within a kind of cultural set of beliefs and practices about history. I will just show you a couple of images. Let's see if it'll let me open these. These are headstones from a New England cemetery coming forward a few decades with each image. This one's quite hard to see. The weather is really sort of battered at it, but it's a pretty fearsome depiction of hell on a headstone, on a tombstone, of death as a skull with wings. And so this is now sort of better preserved, but you can see the downturned mouth. This is still a fearsome image. But if I then, let's close that one. Sorry. That's what makes this a little trickier. If I then turn to, you can normally turn this. Okay, everybody turn your head sideways. Get a little exercise while we're having So I don't know if you can see this, but it's a much more affect-neutral headstone as a representation of death. And in this one, there's even now an upturned smile. And what the graphic representation of death on these headstones in the same New England cemetery tracks is the gradual domestication of the fear of death, the domestication of death. So it's sort of one tiny piece of evidence that he's very good at. All of which leads him to, with a certain degree of moral anguish, worry that in the modern age, and he's writing about the late 20th century, that rather than respond in a healthy way to the unavoidable fact of death, that we are sort of seeking more and more interventionist medical and scientific solutions. And so here's a quote from him that is really at a kind of prescriptive level. Death must simply become the discreet but dignified exit of a peaceful person from a helpful society that is not torn, not even overly upset by the idea of a biological transition without significance, without pain or suffering, and ultimately without fear. And I take that to be an unpacking of some of the same things that Montaigne was saying. Now, one can go in a different direction or come forward a little bit in terms of a kind of major scholarly treatment of mortality. This is Zygmunt Bauman, who died recently. And in one of many books, this one called Mortality, Immortality, and Other Life Strategies, he elaborates on the argument that most modern societies or most sort of civilizational regimes have adopted one of two strategies towards what is unavoidable, that is, mortality is a fact of human existence. And one strategy, what he calls the modern strategy, is essentially to ask science to solve the problem of death. And of course, that is a strategy that's doomed to fail, but it produces a kind of desperation and a kind of clinging to ever more intensive and medicalized approaches to death. And the other, which is also problematic, is to try to avoid death by essentially cultivating what he calls postmodern strategies of virtual life, to live on virtually, to begin to shift your sense of subjectivity now into a dimension that will outlive you. So again, you remain immortal, you don't die. So I could teach a course like that. I could teach a course that centers on philosophy and asks these kind of big civilizational questions. But I actually went in a different direction, in part because of this fellow. So this is a Marchand Sen, who is an Indian economist and philosopher, who's been at Harvard and Cambridge and a number of other places, originally from India, won the Nobel Prize in Economics, not Peace Prize, in 1998. For his contribution to welfare economics, and over the course of a series of books, has tried to make a scrupulously evidence-based argument about how to think about human development and the justice of societies in terms of their distributional outcomes, and regards inequality in all of its sort of manifestations as a symptom of, or a kind of the core of social injustice. And he's most closely associated, I'm just showing you a couple of the book covers, that's a particularly lovely one. And this is one of his most recent books, The Idea of Justice. So you can see from the titles that the ambition of his theorizing grows with each book. So Marchand Sen is associated with what's called the capabilities approach in development studies or development economics. And it was a quite striking move away from primarily economic measures, sort of brute numerical dollar value measures of economic development and economic success, and a shift towards an attempt to sort of assess sort of quality of life in a given society and the distribution of the capabilities that make possible an improving standard of living or quality of life. And it's an approach that is really at the heart of the United Nations Development Program today. So that's how sort of big of an influence he has had singly, and then with really now a generation of scholars using this work. pushing beyond notions that the measure of the success of a society is its wealth or household wealth or GDP per capita and so on. But again, to think about poverty and development in terms of the deprivation or extension of capabilities in the population. So what was really striking then is that here was this very high-powered figure, and in a really sort of unassuming article, which was originally a speech given at UNICEF in Florence in 1995, with this title, Mortality as an Indicator of Economic Success and Failure, what he sets out to do is make the argument that looking at mortality rates is a very good sort of proxy for lots of other social justice and inequality concerns that one might have as a social observer or a policymaker. That mortality rates are really a terrifically nuanced measure and variable. And so that is really the heart of the way in which I began to think about the course that I sort of have gone on to teach for, as I've said, 18 years. And it's a really terrific article, really as a kind of intellectual exercise, because having proposed that we should take mortality rates seriously, he then asks himself, 4 critical questions or 4 reasons why we shouldn't, and is going to sort of respond to each of these. So it's an interesting article in the sense that it models how intellectuals should be, which is, you raise an idea and then you begin to think critically about the idea even as you've just raised it. And so here's the first of the counter questions to the idea that we should look at death rates. Why not rely on measures of available capabilities, which is his approach. So he's actually, in suggesting mortality rates, pushing back against his own legacy now in the world of development policy. So why wouldn't we rely on measures of capability? Well, it turns out it's actually quite hard and costly to gather good data about how widely dispersed are different sorts of capabilities like literacy and quality of healthcare and inoculations and transportation and mobility issues and so on. These are all important things, but they're actually very hard to measure. And what he argues somewhat cutely is that it turns out that for pretty much all of the capabilities, you have to be alive in order to exercise the capabilities. And on balance, the longer you're alive, the more likely you are to actually exercise these capabilities. And so he comes around to the view, even within his own sort of commitment to capabilities, that age-specific mortality is a good proxy for access to capabilities. So in other words, you want to sort of see how well are different subsets of the population in different age cohorts. What does infant mortality look like? What does mortality for under age 5 look like, and so on. And this actually is a good proxy for what he cares about, which is capabilities. Secondly, why not rely on conventional indicators of economic performance, such as national income or income per capita, and so on? And the short answer here is that these are fine measures, but the average can conceal terrific variation. There can be enormous income inequality that is not captured by an average. Now, there are, of course, sort of more nuanced measures of income inequality as well. But his second worry is that measuring wealth presumes that the market is the only way in which services and capabilities might be provided. But services could be provided publicly. They could be part of the public and social investment. And at a lower level of household wealth, you could actually have a much richer life with more mobility and more capabilities and more literacy. And the example that he gave back in 1995 is Kerala in southern India, with fairly low household levels of income, very high levels of female literacy, and very high levels of what one finds to be a felt quality of happiness if one visits Kerala, as he has done many times. And the other thing that he worries about then in this paper is that what income figures can actually conceal is what's actually happening to the lives of people. And I want to just read a quote from this paper, empirically driven paper that he gave as a speech. So here's the quote. While US black men have 1.8 times the mortality rate of whites, black women have nearly 3 times the mortality of white women. It is also important to note that adjusted for differences in family income, so even if you control for income, while the mortality rate is 1.2 times higher for black men, which is still substantial but not quite so massive, it is as much as 2.2 times larger for black women. It thus appears that even after full note is taken of income levels, black women die in very much larger proportions in childbirth and in other ways than white women in contemporary United States. Right? So that's a statement that he sort of says, you can look at the income, but you're not going to notice what is really a quite profound socioeconomic difference. Why not rely on measures of morbidity or suffering? So why do you have to be so morbid and focus on death? Why don't you instead, try to alleviate pain or alleviate suffering? The sort of negative side of happiness would be, reducing pain mitigation, and so on. And there's a couple of problems here. One is that this is a subjective measure. So it's difficult to compare. It's difficult to aggregate. It makes good sense for a physician to, in conversation with you, say, tell me, what's your pain level like from 1 to 10? But it makes a lot less sense to try to sort of develop a pain measure for a society. And then the other sort of really peculiar thing that happens with subjective measures is that when you begin to initiate programs that call attention to something, the rate of reporting of that something can actually go up. So it may seem like now that you've actually got programming going out into the villages to work on pain, now suddenly the pain levels are rising. And to use a somewhat different example, this is a really classic problem on college campuses. So you initiate a robust program to raise awareness and create processes for the better reporting of sexual harassment and sexual violence on a campus. And then what happens? Well, the reported rate of incidences of harassment and violence go up. And if you think about the correlation there, was the program a success? Well, strictly speaking, no, because the problem's gotten worse, but yes, because now there is a kind of confidence and trust in the system and more awareness about the fact that this problem arises. So because morbidity and suffering are a subjective measure, they're not going to be solid in the way that mortality is. Fourth, isn't mortality too sluggish to capture economic and societal performance? That is, aren't we talking like Ares about sort of centuries-long changes in longevity and mortality rates? Well, it turns out yes and no. One of the arguments that Sen makes is that disasters or crises, national emergencies, are really windows deep into the kind of underlying structures of a society. So if you think about Hurricane Katrina and what it revealed about the ordinary lives of people, their vulnerability, the levels at risk at which certain portions of the population were systematically living, and how we responded, you actually begin to get some clues about whose lives mattered more. If you think about Puerto Rico more recently and the sort of fiasco of response, still unfinished, that too is arguably telling. But I would also point to something that I'll come back to in after the break, and that is opioid deaths, which was a rapidly changing figure. And had we actually paid more attention to it sooner, we might have been able to do things, sort of attend to more solutions earlier. We really waited a long time, and the numbers were there. So that's what Sen would say. And here's sort of the point that he comes out with then at the end of this speech that became an article. The quality of life depends on various physical and social conditions, such as the epidemiological environment in which a person lives, the availability of health care and the nature of medical insurance, public as well as private, are among the important influences on life and death. So are other social services, including basic education and the orderliness of urban living and the access to modern medical knowledge in rural communities. The statistics on mortality draw our attention to all these policy issues. Mortality information can throw light also on the nature of social inequalities, including gender bias and racial disparities. Okay, so this for me was manna from heaven, because this was a sort of well thought out, high-powered kind of intellectual justification for what I had been kind of groping towards somewhat intuitively, and why I wanted to teach a course on death. So let me shift gears then and sort of show you. So the hapless students show up in my class, and they, it said death in America. They have a vague sense that I'm supposed to be a good teacher, but how do I sell them on why they should want to spend a semester talking about death? And I'm going to show you some artworks, because again, I think there's a lot of profundity in art. So this is Gustav Klimt's Life and Death. And this, for me, visually is the embodiment of the passage I just read from Sen, and that is that the collective and interdependent sort of recognition of that the lives of everybody matters is an awareness that you can have when you understand that you collectively face death. It's just a tremendous image. And you can see that Klimt, the Austrian painter, has gone out of his way to sort of have sort of young and old and white and other skin colors, which is quite radical, frankly, at the time. So that's Gustav Klimt's Death and Life. And so here's the reason that I have a course on death. Because death, that is the mortality rate, is a potentially robust indicator of what ought to be a fundamental communal concern involving public health and social justice, namely the patterned maldistribution of life chances, morbidity, and ultimately mortality. Right? So that's the mission of the course. That's the, if you will, the sort of running assumption of the course. Now, again, more specifically, why? First of all, death is everywhere. This is a massive painting. The real painting is quite massive. And admittedly, it's a fairly apocalyptic account of the human condition. I don't think you need to have an apocalyptic account to realize that death is everywhere. And this is the lower left corner of that painting. We are all vulnerable to it sooner or later. So there's a king, even kings die, right? We all die. Third, yet we don't think and talk enough about death. So back to the discomfort of my faculty colleagues and my sort of perverse insistence that I'm going to teach this course and have death in the title, is because we don't. Now, if I go back to the painting I just showed you, Gustav Klimt's Life and Death. Now, admittedly, this is not always the case, and this is a rare example I'm going to show you. But if you go to this one particular website to buy this poster, what you get is that. They have visually X-Acto-knifed out death. Because, you would, and it's still called Death and Life. This is bizarre. I mean, if you want to see a visual example of the difficulty we have still today talking about death, it's there. So we don't talk about it enough. And because we don't talk about death enough, it shows up in odd and obsessive, even obsessive ways. This is a very famous painting. It's quite a large painting. I actually saw it in the National Portrait Gallery in London. And there's this weird kind of smudge down in the bottom of this painting. And I think, let's see if it'll let me do this. That's the smudge. And so this is a painting that would have sort of hung on the wall as you entered the room. And the first thing you would see is actually the skull. So it's been painted at an angle, at a compressed angle. And so if you came in and saw the painting at an angle, and then you would see the two brothers, one a man of cloth and the other a man of business. But I find this quite fascinating that the artist chose to do this. And I would venture to say that it's because we don't talk enough about death that we actually subject our children to enormous amounts of visual violence and death. And you do get these sort of estimates that blow one's mind about, the average 16-year-old will have seen 10,000 deaths if they're a consumer of, popular media. And yet we don't talk about death. Fifth, our impressions about real deaths are often arbitrary, inconsistent, and judgments accordingly mistaken. So we might value the death of a hero, and we might want to avenge the death of a hero and kill any number of people to avenge the heroic death. We don't think of deaths as being equal. We imbue some deaths with meaning, and others we think are meaningless. We don't care. We're indifferent. They're just numbers. In terms of this worldly ethics and public policy, human death is an ultimate stake and hence ought to be an ultimate criteria. And I don't want to sort of second guess whether or not you feel that you will come back or rise on the great day. But for the most part, most of us lie dead once we die. And who knows what comes afterwards. And so the sense in which in this worldly material terms, this is an ultimate stake, an ultimate criteria for ethical purposes. And this, for me, is an important move, and this was part of, frankly, my justification for going to death as a kind of ultimate stake. Although we might disagree on philosophical or partisan grounds about many things, we should agree that involuntary and or premature death is a bad card to be dealt. Now, there are still some really tricky issues around using death to try to resolve partisan differences of being abortion and being pro-life, and is clearly one. And I will not take any questions on that one. But for the most part, the idea is you could come from conservative principles or liberal principles, but surely we can agree that there's something unfair about an America in which certain categories of people are dying at substantially higher rates than others. Right? That's the sort of the ethical lever, if you will. And then 8, fortunately, and this is to pick up on Marchand Sen, in contrast to many other criteria for policy evaluation, deaths and their distribution are relatively easy to identify, count, and map. So you now get sort of maps that generate and display and disperse data on mortality terrifically and very readily. The CDC, I think that's here, now generates sort of yearly measures on all of the leading causes. It breaks them down by race and so on. When I first started teaching about death, data was very hard to come by. And it's really been quite terrific because you can now really hone in on sort of distributions of mortality. So those are my reasons, and I have a bit of time. So let me pick one of the examples that I've given, and this is not a fun thing to talk about. This is not a fun thing to talk about. But if we don't talk about it in classrooms, when will people ever talk about it? And so I want to talk about what we know in the US about the infant mortality rate. Here are the two scholars whose work, funded by the Kaiser Family Foundation, is where I'm now going to go. And you may know some of this, you may not. Let me just walk through some of the kind of bigger points of comparison. Here's the first one. Infant mortality is higher in the US than in comparable countries. So there's the latest numbers, the latest data, which, there's always a lag. This is 2014 data. And, in the finer details of this, they do say, look, that there are measurement differences and so on, but the belief is, even if you correct for definitional differences, there is no avoiding the fact that the US has a problem relative to other advanced industrialized countries. The actual sort of all-country average is 3.4, and we are at 5.8. The good news is that the infant mortality rate has declined everywhere. The bad news is the rate of the decline in the US is slower than it is in other countries. So every country is doing better. The US is doing better at a slower rate. Okay, so good news, but modestly so. And then here's what Marchand Sen says, pay attention to, that is, disaggregate that number, because it turns out that that infant mortality rate, which is already higher, almost twice the average for all OECD countries, that average conceals considerable variation. Black babies die at much higher rates. Okay, so here's the breakdown. These are the all race averages in 2000 and 2014, blue and green. American Indian or Alaska Native, Asian or Pacific Islander, black non-Hispanic, Hispanic, and white non-Hispanic. Now, the good news is that all of these columns are shorter in the second color, so there's been progress made across all race categories. Though there has actually been some data really recently suggesting that the number has actually risen for black babies, quite recently. If one goes even more specifically and talks about neonatal mortality, again, in the US, we're number one, which is to say we're the worst. We have the highest rates. There's the all-country average, 2.3. We're at 4. Again, some of this is measurement, so I would say that you'd have to blunt this a bit, but not by a whole lot. And again, neonatal mortality is improving, which is to say it's falling, but it's falling at a lower rate than the OECD averages. Non-Hispanic blacks, so there's the race variance in terms of neonatal mortality. This is the black number. This is American Indian. This is the all-race average. And so you can see that there's a gap there. Now, it's a separate question to then sort of try to figure out what is the explanation. But I think the first step is just knowing there is a gap, and we need to be talking about this. We need to be talking about the fact that there's a gap between the US and all other countries. We need to be talking about the fact that there are large gaps within the experience of being a parent and giving birth. Here's the perinatal mortality, and this is the one where the US is actually doing better than the comparable country, all-country average. And that's the sort of a little bit of good news. Post-neonatal mortality, and again, there's the huge gap showing up again. And then one can get into sort of very specific issues about what are the causes of infant mortality and congenital malformations and so on. Low birth weight turn out to be sort of leading causes. And this then these become clues to, what are the causes, where might the solutions lie if we first agree that there is a problem that this is happening in the United States. Okay, so I'm ending on a really grim note. This, for me, is the image that you really want to internalize. This is the image that I want my students to internalize. And so it is the case that I don't push a particular ethical view or ideological or partisan perspective on my students. I'm very proud of the fact that I will have students across the spectrum who know that I will take them seriously. But in this course, I do sort of want them to, I do ask them to think about the way in which the fact of finitude, the fact of mortality, and the unfairness of when death visits is something that we should all regard as a problem. That is, it's a collective undertaking. Okay, and with that, I will stop and see if you have any questions.
Am I on? Okay. This is Hans. I have a comment. I have a family history. It goes back, a century and a half or so. And it's amazed me that the infant mortality, where the family's children didn't survive in the earlier years, if they didn't survive at birth. Of course, economic situations and wars and so on had a lot of influence there. But then there was a comment there also stating that children were not often named until they were at a certain age, because you might not keep them.
No, so, and that is why the secular trend pretty much around the world, outside of countries that are war-torn or ravaged by famine, the infant mortality rate is dropping. And it was very high everywhere, in America and in Britain. And so yes, infant mortality was high, maternal mortality was high. I can tell you, it's a tradition in India that you actually have a naming ceremony at 6 months. And we actually, because it's a kind of cultural thing, we did this with both my daughters. That it's not like we didn't name them, though that is actually technically the practice, because you don't commit emotionally to the baby until 6 months have passed. And in fact, they have a kind of it's a naming and coming out ceremony. That is, you share the good news of the child at 6 months. And that's a testimony to the fact that infant mortality was very high, and here's how you kind of cope with this culturally. But in terms of the contemporary situation, I would just keep saying that it's a very serious moral issue in the United States that the infant mortality rate is as high as it is, that we don't do more in kind of prenatal care, we don't do enough in follow-up care. We kick parents out with a car seat, with a 15-minute car seat training, and that's it.
This is Rosamond. I was interested in your graphs that Canada is just behind the US in terms of high infant mortality, and they have universal health care there. So do you have any more information as to why they're so high?
I don't. I'll make one. So I'm also Canadian. So I'll make one point about that. Technically, Canada does not have universal health care. What it has is a single-payer system that is regulated at the federal government level by a series of principles on the fair distribution of health care. Provinces set their own plans, and now de facto it still means you're covered. If you're a Canadian, you're covered. I think it is probably the case that there are still minority populations. I can think of the First Nations people in Canada whose birth rates, infant mortality rates are much higher. But it's not a huge population, so I don't know why that would still produce such a high rate. Because I certainly think the pre-coverage and post-coverage are better. So I don't know. That's the short answer. Yes. I'll repeat your question. I think, yeah.
I think it's important. I think we are afraid to talk about death. I mean, my husband died suddenly. I was comforted by the fact that I knew what he wanted to have done. So I sat down with my daughter, who was quite uncomfortable. But she has now not only what I want done, but I've written my own obituary, which I must go home and kind of refresh a little bit.
Well, and I mean, and again, I think death is shrouded with so much fear and anxiety, and if you can find ways to laugh about this, and so in my course, I have students, write advanced directives. Young people die. They go try to climb Smith Rock and they fall off it, and there's nothing. We don't know anything about what their wishes are, and so. Frankly, even the task of writing an obituary, I think, it's an interesting chance to self-reflect and take stock of one's life and accomplishments and so on in a healthy way. I will say that Oregon is a leader in the hospice movement and use of hospice movement, and there is more of a conversation in the United States. There is a trend, though it's died down a little bit, to have what's known as death cafes. particularly to talk about end-of-life issues. But even in the U.S., even in Oregon, and certainly nationally, hospice, which technically, it sort of is supposed to kick in with a diagnosis of about 6 months, most of the users of hospice are 6 weeks, 2 weeks. I think 2 weeks is actually the place where people officially say, okay, now it's time for hospice. And I frankly think that's a shame, in the sense that up until that point, one is still fighting. And to go back to, the Aries text and the Bauman text, that one feels like one has an obligation, and there is a kind of momentum coming out of medicine, coming out of science, to use, one more machine that goes ping. And it seems to me if you can take care of pain, but then make it possible for somebody to have a kind of conscious interaction and make peace with whoever they've interacted with, that's a better course of action earlier.
Professor Basu? Yeah. My name is Franca. The disparity between the mortality, or the big gap between the African American community is obviously is not totally related to socioeconomic situations. There are other factors. And recently, today actually, I heard on NPR that there were African American women who were harassed at work because of their hairstyle. It wasn't white enough for the white coworkers, and the coworkers would tell them, "We are uncomfortable with the way you wear your hair. I mean, you were born with it. How can you change that?" So that's stress, and one of the factors on infant mortality among African American is stress. Also, and African American children are more likely to be handcuffed in a school if they're acting out, as opposed to someone who's not African American. That is a huge problem, which has nothing to do with socioeconomic or access to health care.
Right. I mean, I would just agree. I will say that there is sometimes a rush to the view that if race is a variable, then there must be racism. And I think the only sort of qualification I would make is that it is often the case that there are racialized differences in the data, and sometimes that is about socioeconomics that maps onto race, and these are converging impacts. And race can have an impact on the socioeconomics, which can then be the driver of the difference in mortality rates. But geography is also a factor often. So if minority populations are in urban areas and they are visible to police surveillance, then they're going to get prosecuted and pursued at higher rates. And if white populations are living in dispersed parts of America beyond the sort of regular surveillance of the police, then the interactions are less. And so what might look like it is overtly a race variable can turn out to be a spatial variable. It can turn out to be passed through, if you will, intervening variables. But I take your underlying point to be absolutely right. I mean, what we are now discovering is that there are lots of traumas associated with not being allowed to feel welcome. That is, one is absent from this painting in the mental image that many Americans have of America. And that is a stressor, that is a kind of source of trauma that has profound impacts on adult health. I might do a tiny bit of advertising. So there's a film playing tonight at the Grand Theater, 7 p.m. The title of it is Resilience. It is a documentary about the relationship between childhood traumas, some of which can come from just the fear of, how society views you, how it will treat you, how it has treated you. If you grow up in a home that is unstable, in which there is violence, that these get written into the fabric and the chemistry of your brain, into your body. These damage your organs in ways that leave them vulnerable decades later. And you're starting to see that kind of scientific work, that longitudinal work being done. So it's a terrific documentary, and it's followed by a panel of local public health figures, including the director of the Liberty House, the Child Abuse Trauma Center in Salem, and a couple of other folks. So if you haven't had enough, then I would really encourage you to come. I think it's free, or it's a nominal charge, $5. Yeah.
Hi, this goes along with this whole discussion we've been having. When I was very young, I remember my mother telling me that I was part of a prenatal nutrition experiment. And looking at your figures on prenatal and perinatal, and obviously nutrition must play some significant role in the survival rate of children, generally speaking. But to me, it seems odd that countries that we would consider maybe not so nutritionally solid as this one have a lower death rate for children. And how is that accounted for?
I mean, we'd have to go look at the data really closely. I'm reluctant to make overarching statements. What I can say is that, it turns out that if you're poor in America, the cheapest food is also the worst food, right? So there is a kind of food scarcity problem, the food that's ready at hand. If you're working 2 jobs so that you don't actually have time to prepare food in the sort of old food movement way, then the prepackaged, pre-prepared foods, which are cheapest, are not going to be good. So if the mother is going into a pregnancy already, problematically nourished, if there are lifestyle factors that also harm the fetus, I mean, so these are prenatal factors. There's been some, I think, mixed feedback on breastfeeding, and are you showing more love if you're breastfeeding, or if you're buying some chemical product that is a substitute and that's easier, certainly if you're going back to work sooner. I would say that the sort of length of off work coverage post-birth for one or both parents is, we're on the less generous side, even in comparison to countries that are less affluent than us. So I think you have to start looking at all of those factors and how they converge and how they're not distributed evenly, so that the mom or the household that is already challenged in a number of socioeconomic ways is also the one that has the least access to health care, is also the one that may have already been written off by some of the social services because they've looked at them and said, well, that's your lifestyle and it's not worth wasting a lot of programming on you. And they may not have thought it, but their body language has conveyed hostility, or in some other way at a not fully expressed level, there's been a kind of felt failure of communication there that sort of damages the prospects of the baby and the mother.
Sammy, it's Ann. Let's look forward to the prison situation where the black population or people of color are so much greater. Does that ricochet all the way through?
Yeah, so
Mortality?
I mean, the absence of black men in family structures and social structures. You're already seeing, sociologists are already seeing this very interesting phenomena where there's a generation of young people and their functional guardian is their grandparent. That is because their own parents have, for various reasons, turned out to be dysfunctional as a couple, or dysfunctional as a household, dysfunctional as breadwinners. And you're extremely dysfunctional if you're in prison. I mean, you're just failing to cope at any level and failing to be present for your child. And those, I mean, that the grandparents can step in as they are doing in growing numbers is really terrific. And in some ways, that's almost more wisdom than the parents might be able to offer because they've come through it all. But it does leave holes. There's a study that I share with my students about the trauma of a premature death in a family, in a household, in a social network has kind of repercussions, particularly if it isn't talked about properly, or if the death feels unfair, or if it was a result of, help that didn't come soon enough, or it didn't come in the right way, and that itself then kind of eats at the kind of psyche of all of the family members. So I'm not talking about just a death in the family, but the notion of its prematurity, of its kind of being brought to bear earlier than it otherwise would have, is a real challenge. The other phenomena. So yes, prison populations and the impact on those communities. The other really, really huge problem that America is not yet, I think, facing is, I think we should all get medical care, and we should all have life-prolonging treatments. And so, I'm not for death panels or anything like this. But I do want to sort of state that if you keep the physical operation of the body going, then what will give out is the brain. And you are now seeing households in which somebody has Alzheimer's for 20 years. And this is an ethical challenge, I think, because the primary caregivers are engaged in what is increasingly all-consuming and thankless work of love and care of somebody who increasingly doesn't even recognize them anymore, and who is needing more and more care. Because we've gotten so good at keeping all of the bodily functions going, it's the brain that gives out. And the toll that can take on family members is enormous. It's really enormous, and the cost of it is really enormous. And that's what's coming. So I have a number of my students who in this death class will do service learning, experiential education. I was really encouraging students to get out in the community, and and one of the things that students will sometimes end up doing is going and volunteering at one of the sort of mid-level Alzheimer's care facilities in town, and it's a galvanizing experience. It's a lovely experience, I think, for both participants on both sides. But it runs like this. Sally will go on Tuesday and explain at great length who she is and what she's studying, and the elderly person with Alzheimer's, who's still very intelligent and very present, but has no continuity or has no control over continuity, will engage in that moment with who Sally is, and then she'll come back on Thursday and do the whole thing again.
Professor?
So I've tried to sort of share the thought process and justification for a course that I've taught for many years, and one of the reasons why I've kept with it, aside from the intellectual satisfaction, because I think it is something that we need to be talking about, is that I've heard over the years from students who've gone out into various walks of life, and I teach a variety of very different things, and this is the course that would often get very specific responses back, sometimes years later from a student who, they were a B+ student, and now they are the chief lobbyist for the California Medical Association, and they were involved in the arguments around advanced directives and assisted suicide in California, and so they thought of me. They wrote back, and they wrote and said, that stuck with me, and isn't it funny that now this shows up. Or a woman who had diabetes and goes on to become, now very high up in the American Diabetes Association, and just learning to think about, a certain kind of condition that she has and its impact on her life chances, and not as something to suppress or play down, but to really treat as a kind of window into what contribution she might make to society. So. What's happened over the years is that I've kept plugging away, and I had a colleague in sociology who taught a course on death and dying, and she has since retired. But we picked up an anthropologist, Joyce Milland, who you probably know, and maybe she's talked here, who is actually in addition to being a medical anthropologist, she has a master's in public health, and we have now a new colleague in environmental sciences who also does environmental health. And so the faculty capacity to teach about public health, which is how I sort of, where I have ended up in thinking about mortality. We now have faculty, and as I'll share in a moment, as a result, we've just, literally last week approved a new major, unless the trustees object, which they won't. So I thought I might just say a few words about what public health is generically, and then ask you to celebrate with me the fact that there is now this new major. And then I want to talk a little bit about what a public health approach to something like the opioid crisis looks like. In other words, how can I imagine, and in fact, since I do teach it already, how would I teach this? How would I get students to learn to think about the opioid crisis from a public health perspective? So there's lots of words that swirl around public health, and maybe you already have a clear sense, and maybe it's still sort of cloudy, and you're trying to get a grip on what public health might mean. And I've been told to not to keep scrolling around, so I'll let it sit. So here's sort of the industry accepted definition. It's nice and short. This comes from the CDC, or actually I think one of the public health kind of academic organizations actually. And the idea is to begin to encourage sort of communities and policymakers to think about their own work from a public health perspective. So it's a very simple definition. I'll read it if you like. Public health is protecting and improving the health of people and their communities. And since I mentioned sort of that public health is really asking that policy be thought of in terms of how it implicates health. And so, again, this is just a visual. It's going to be a little hard to see, but it turns out, if I just quickly read off some of the items here, as policy domains that can impact public health, complete neighborhoods, family support, adult and child care, good schools, recreation and open spaces, public transit and active transportation, quality environment, safe public spaces, community-oriented media, affordable and quality housing, green and sustainable development, information technology, fair justice system, healthcare, universal design, economic opportunity, healthy food. Right, so you're pretty rapidly talking about policies that on their face you might not have thought to articulate in terms of health impacts, but rather economic impacts or other impacts. But public health is really a way of sort of starting to sort of put particular kinds of implications of policy on the horizons of policymakers and community advocates and so on. Now, there's a distinction then to be drawn between public health and what is sometimes referred to as precision medicine or clinical medicine. And so in public health, we're not going to teach any students how to give injections or do any of that one-on-one face-to-face work. So the distinction between public health and clinical medicine is the sort of face-to-face point of delivery at the individual level, as opposed to public health, which is sort of understanding the causes and factors and hence the interventions and solutions, responses to discrete populations and subpopulations. So there's a macro dimension to public health and a micro dimension to clinical medicine. So this is a good distinction, but I would not want to overdraw the distinction because I think increasingly sort of socially conscious doctors and physicians and nurses and so on who have the time are realizing that the care that they would give the individual is really predicated on a series of nested circles and context. And you really need to know not just what medicine to give them, but what else is impacting them in terms of stressors and demands and lifestyle choices and so on. And similarly, from the public health side, that one needs to be able to sort of think about big structural causal factors, but how they actually impinge and play out at the level of individuals. That is, sort of program interventions to be effective have to be sensitive enough to what's the best intervention, sometimes even at an individual by individual basis, but recognizing that that individual is the sum of all of the causal factors. So there's a sense in which these two things should be converging. But the distinction is a kind of historic part of the way public health defined itself. So this is the CDC, the Center for Disease Control's old and still sort of current definition. Public health professionals try to prevent problems from happening or recurring through implementing educational programs, recommending policies, administering services, and conducting research, in contrast to clinical professionals like doctors or nurses who focus primarily on treating individuals after they become sick or injured. Public health also works to limit health disparities. A large part of public health is promoting healthcare equity, quality, and accessibility. And so for me, the ethical connection between a focus on mortality in the way that Marchand Sen said we should as a good proxy for other sorts of equity considerations, and what public health can also be about, which is attending to sort of variations in life chances and longevity and mortality risks and rates. Those really are the same thing for me. So it was a kind of natural, kind of intellectual move from a course on death to thinking about wanting there to be coursework and even a program in public health. Now this is the main diagram the CDC's used for a long time, and I just don't find it very helpful. It's really quite bureaucratic, and I as a kind of public information image, it's kind of useless. But assessment, policy development, assurance, and then system management, research, monitor health, diagnose and investigate. So it's not that it's wrong, it's just not very, informative. I mean, I'm not going to get excited about public health if you show me this. But so here are some other images that other sorts of organizations who now see their role as being about, helping people to understand what their commitments to a community might look like in public health terms. And so I sort of like this a bit more. All of these are part of the underlying determinants of health. And if I go back to that first image I showed you with all of the policy domains, so discrimination, stress, and trauma, that's to pick up on the observation you made, food security and access to nutritious food, housing, environmental quality, transportation, education, healthcare, neighborhood health and community environment, income and employment. So again, the idea is to begin to think about and get the public to begin to understand and to articulate and advocate for themselves, and to some extent to understand, why it makes sense to pay taxes and why and where you want your taxes to go. That is, we're all better off if we can attend to public health in particular ways. At the individual level, and again, this is to sort of suggest the point of convergence between an individualized approach to medicine and a public health approach is, the point of convergence is in being able to help an individual think about all of the things that impact them personally and impact the quality of health that they may have. And these percentages are sort of controversial in the sense that these are sort of estimates that are rooted in longitudinal data, and you could sort of push and pull a little bit on how you think about these percentages. But you're certainly seeing proponents of public health who want to say that as much as 40% of one's health chances, life chances, are tied to socioeconomic factors, and again, this is a long list. And I've mentioned that it's now possible to get really good data. It's possible to get data now that is spatially disaggregated, sort of at the micro level, at the neighborhood level, and there's a lot of really good work being done, basically plugging in zip codes. So if you know what somebody's zip code is, you can have wealth averages for the zip code, and there's all sorts of information that is somewhat crudely, because a zip code can contain considerable variation. But it turns out that just running zip codes on various other health factors begins to produce an image, which is grand because of its statistically big size, demonstrating these sorts of impacts. Physical environment and then health behaviors. Nobody's about to say that people don't sometimes make bad choices, or that if they curtailed or changed what food they put in front of them, how they snack, what they drink, what sorts of other sorts of intoxicants they take, how much they exercise, that this doesn't have an impact. So there's still obviously an individual dimension to all of this. I will just say, and I was in the talking to somebody privately, that I think there's good reason to think that a lot of smoking's down, vaping is now up with teenagers, but that a lot of smoking, maybe as much as 30% of people who were smoking during the 80s and 90s, they were actually self-medicating for depression. And when you sort of realize that, okay, they weren't doing it to look cool, they were doing it because this is a sort of relatively cheap and accessible form of mental self-management, that sort of changes your kind of understanding about why were people smoking. It's a self-destructive behavior, but it was performing a mental role. I think there's something to be said for alcohol abuse, particularly before it becomes an addiction, that it is about, a kind of culturally cultivated habit. It's become quite a problem in Europe, actually. Sort of binge drinking on Fridays in Britain is a big problem amongst the working class. And it's sort of culturally tolerated in ways that it shouldn't be, but it has something to do with the fact that those 5 days a week, that work was not fulfilling, and it wasn't earning enough to sort of leave one feeling happy and looking forward to the weekend. And so drinking heavily is all you've got. And then healthcare, and access to care, and then the quality of care. One of the things that I will say about healthcare is that you often get that crude number of how many are uninsured in the United States. But I think if one's going to be sort of smart about this, you have to give both the uninsured and the underinsured number. Because there are lots of people who are technically not uninsured, but whose insurance, such as it is crappy, or it is with co-payments that are so high, or it is with various sorts of more drastic problems. It is going to sort of the policy that they have, or the program that they've opted into, just isn't going to cover it, and so technically they don't count as a kind of problematic consumer of healthcare, but they are a problematic one. They're very vulnerable. It turns out if you don't have good dental care, so healthcare is one thing, dental care is another. The sort of the downward spiral into homelessness can often begin with something like dental care. You get an infection in a tooth in the front, you can't pay to get it taken care of. You're now showing up to work in pain with a tooth that's smelly. You get crabby with somebody you're interacting with, as a customer. The boss sees this. Now you've lost your job, and you spiral downwards from something that, had it been taken care of, had you been covered, you wouldn't have been moved from the front of the business to the back room and then out. And again, just another sort of image. I know these are hard to see. Just from your distance, I would just say the stacking of these layers. So this is a healthy society, a healthy environment, healthy community, healthy people. And the notion that these are sort of stacked, or they're really nested loops, and to get individuals to understand that they are impacted by where they are inside these loops. Again, this is just another way of trying to communicate the social determinants of health. One of the things that we're still, I think, in the healthcare system wrestling with is provider linguistic and cultural competency. I've had a really terrific student recently who is a Latina, and she's been really struck And she wants to have a career in clinical medicine, but really struck with the relatively culturally incompetent nature of the medical care by otherwise, very liberal and loving healthcare workers. They don't know the cues, and they're making mistakes, or they're approaching topics in ways that are going to, shut down the patient or shut down the patient's family, and they're not going to get good information, which is vital to diagnosis and vital to delivering treatment. So public health is really about sort of wanting to pay attention to all of these things and wanting to train people to juggle all of these variables and all of these factors. So the government and the CDC in particular, has launched so far 3 public health kind of grand visions, all of them underfunded, but all of them well-intentioned, and with a lot of people really putting sort of lifetimes of effort and experience into them. And so the latest one is Public Health 3.0. And it really is, you can just read this maybe, a call to action for public health to meet the challenges of the 21st century. And here's a quote from one of the authors. To solve the fundamental challenges of population health, we must address the full range of factors that influence a person's overall health and well-being: education, safe environments, housing, transportation, economic development, access to healthy foods. These are all the major social determinants of health, comprising the conditions in which people are born, live, work, and age. One of the more recent developments in public health is to begin to try to demonstrate the cost impacts and health impacts of climate change, both directly and indirectly, in terms of how floods and things will produce bad behaviors or will produce kind of dislocations of populations from their homes and so on. And this is fairly new. I will say, though, that one of the early pioneers of this approach is a fellow by the name of Terry Tamminem, who was the California EPA director. This is the fellow who actually turned Schwarzenegger, when he was governor, from being what he had been, which was a poster boy for the Hummer, to being a poster boy for the Prius, and for initiating, under his watch, a lot of very profound changes in the kind of infrastructural planning of California. So Terry Tamminem was the fellow, who really kind of shifted Schwarzenegger. He's a little guy, but he wrestled Schwarzenegger intellectually on this one. And in a book called Lives Per Gallon, Tamminem makes this very interesting argument, and that is, rather than wait for climate change to reach the point where, the emaciated polar bears are now storming the cities, the icebergs are showing up in harbors in Seattle. What you actually do is initiate class action lawsuits where you connect asthma rates to industrial pollution. That is, you don't wait for those big cataclysmic changes to happen. And the model here is the master tobacco settlement that a number of states attorney generals engaged in with big tobacco. Basically, sort of saying, look, here are the costs that our society has incurred. There's enough evidence to suggest that you willfully, knowingly marketed products and engaged in business practices that cause these harms, and so we're suing you for some portion of the damages. And so there's a way in which this is a kind of kindred notion, trying to connect climate change to a number of modalities. These are hard to read, I know. Undernutrition, impact on mental health, cardiovascular disease, respiratory disease, harmful algal blooms, vector-borne disease, and so on. Oregon is actually a relative leader in this. I'll just show you that this is the Public Health Division of Climate and Health Program of the Oregon Health Authority. And there's a terrific woman who's actually in charge of this particular programming. And it's, again, there's a public education dimension to public health. Public health isn't just about doing these studies and producing these terrific regression analyses about the causal factors. It's about pivoting in order to face the public and to try to inform them about why, your kid has got asthma and nobody in the family had asthma before. Where is this coming from, and why should this matter, and how as a society might we respond? So just to pick this, but respiratory disease, gastrointestinal disease, violence that can result from the displacements that, kind of weather emergencies that can cause, and so on. The other big one that is really something that we do need to be taking seriously here is the coming earthquake, which will have really quite devastating impacts to us. I-5 will not survive. Most of the overpasses will fall. And that's our main transportation corridor for emergency services, around the state. There are obviously secondary roads and so on, but these things are going to be collapsing. There is analyses even of Salem, and a serious earthquake will cut off quite substantial chunks of Salem. I mean, it will make it very difficult to get around, which is one of the reasons why this program has really taken off in this area of the country, the Community Emergency Response Team, which is about both sort of sharing basic first aid, but also encouraging folks to keep at hand a kind of emergency store of supplies, including fresh water, which will be one of the sort of most scarce things in the event of a serious emergency. And so public health is also about this, which is, how can one sort of shore up the resiliency of communities against big incidents of gun violence or of other sorts of natural disasters, in addition to the kind of long, slow creep of climate change. Okay, so that's public health in general, and so this is my sort of coming out party, if you will, and that is that the faculty of the College of Liberal Arts voted to create a program in public health, which we are going to call and have. Sorry, I'm spinning, and I said I wouldn't. HEAL. HEAL is the acronym we're going to use for this program. In order to emphasize the confluence of these four things, so or health, but health in terms of ethics, advocacy, and leadership, which is really about sort of how do you improve the literacy, how do you improve health education, how do you advocate for populations who may not understand why there are sort of health impacts occurring in their communities, and they don't understand, they can't connect the dots. It's to sort of help them do that. So it'll be both a major and a minor. So there's me, there's Joyce Mill in anthropology, and then a number of affiliated faculty, folks who, although already very busy, are willing to participate both intellectually in the future of the program, but also with courses that they currently offer. And so, what does the study of public health look like at an undergraduate institution? And so, in sort of fairly straightforward terms, my hope is that what the program will do is improve students' abilities to do the following things. So, first, identifying the public health problem and its differential impacts on subsets of the population. And so I want to stress all parts of what I've just said here. It's not enough to know what the average rate of X is. What we really have to start paying much more attention to is what's the rate of X in this population and that population. I can tell you, for example, that suicide rates, some of the highest suicide rates in the country are white men aged 50 and older in rural parts of America, particularly where there is access to firearms. It's not that the subpopulation is always going to be a disadvantaged urban minority. I mean, there's lots of different ways in which health impacts and mortality impacts play out measurably. And so identifying what are the problems and for what populations are these problems is the first step. So second would be advocating for those populations. So talking to them, understanding, you know, what their situation is, and then advocating for their needs. So these are populations that are otherwise often lost in averages and lost in statistics, who may not trust the conventional sort of institutions, or who may be like the rural white male, taciturn, too proud, too individualistic, to sort of acknowledge that they're having any sorts of mental health challenges, for example. And so advocating for these populations involves, you know, not speaking for them, but speaking with them in order to help them to speak for themselves. Third, developing a holistic understanding of the interactions between multiple causal factors. So this is why I've long felt that a liberal arts college is really the best place to begin to train somebody, to train cohorts, to train a generation to think about public health. And that's because just being really good at science isn't going to get you there. Being pre-med and then turning to public health tends not to work. What you actually need to do and know is you need to know something about the global political economy. You need to know how the long process of deindustrialization in America has left certain parts of the country feeling bereft of economic challenges and seeing their economies shrink and dissipate, and that they now have skills that have no value in the manufacturing and industrial sectors of the United States. And you need to know enough about global political economy to sort of understand what's happening in a local community. But you'd also need to know about science, and you'd need to know, you know, what's occurring in the new science on brains and on what we now know about addiction. And so you actually need to know a lot. You need to have cultural competency. You need to be prepared to talk to populations who are new populations in the United States or who are mobile populations in the United States. And so the holism and the multiplicity of factors, both of those things. And then formulating solutions attentive to the populations impacted and to the various causes of the problem. So unfortunately, it is very rarely the case that where public health problems are concerned that there is a single solution. And that's because there isn't a single causal variable. There's usually an interaction between multiple variables, and any sort of good strategy has to be a multi-pronged strategy. It would have to deal with all of the moving parts. And then finally, communicating and implementing the public health solutions. So one of the things I've sort of stressed in the images I was showing you before is that it isn't enough to do the science research and to gather the equations and the regression analyses and so on. You have to then convert that into something without dumbing it down, but that makes it legible and intelligible to populations who don't have the leisure of perusing your, the little levels of significance on your statistics. And so you have to be honest, and you have to sort of register the fact that these may be estimates or that there's a range, but you have to sort of do the work of communicating. And implementing. You can't just impose programs on populations. You have to make them understand. Because amongst other things, otherwise they're not going to cooperate. They're not going to sort of follow the recommendations or follow the instructions. Okay, so I want to just work on the example of opioid abuse and the opioid overdose death epidemic with you as an example of how those various ways of thinking about public health should go forward. Now, can you tell me how much longer I have? 20 minutes, okay, awesome. Less. Okay, I'll be done in less. I'm good. Okay. So, as I said, when I first started teaching about death, it was very hard to come across good numbers. It was very hard to sort sort of, find graphics that helped one to understand things. And the revolution that has occurred, is a revolution in the sense that the information is now available in ways that I think us ordinary folk can understand. And I quite like this fellow's work, Josh Katz, in the New York Times. And I want to just work through these really quickly with you. And what I will say, at the risk of sounding like I'm tooting my own horn, is that in my death class, because I was going and finding the numbers on the leading causes of death, I will say probably 12 years ago, in my class, we already started talking about the fact that opioids are rising, because they were moving up. In Ohio, famously, they jumped above car crashes as I think the second leading cause of death or something. And so you saw them climbing in a number of states. But it was only because I was doing this weird thing. I was looking at death rates. And people weren't talking about that, and now everybody is. Here's the scale. Sorry, again, I'm doing it. Here's the scale of deaths. So in 2016, an estimated 60,000. And what they've given you here are the peaks in annual death rates from other leading causes. So car crash deaths in 1972, particularly bad year to be on the road. So that was the peak, 55 or so thousand died of car crashes in 1972. The peak number of HIV deaths in 1995 is right around here, so 47,000. So you just begin to understand how many people are dying from opioids. Peak gun deaths in 1993, 40,000, right? So the scale of this problem as an annual killer, very high. And then being able to disaggregate by county. So Ohio, is one of the ground zeros of opioid overdose deaths. It's also one of the ground zeros of the deindustrialization of the Northeast. But there can also be these very interesting and mysterious and actionable, if you want to think about where should our public programs go. Well, if I've got the data on where people are dying at higher rates, maybe that's the place I start. So I wouldn't want a program evenly spread across all of Ohio. I would want to sort of really hone in. And so, having good data that breaks it down by county really helps. So one of the things that's now looming is fentanyl. So this is now showing up. This is very lethal, very potent. So just a few grains of this in what is already problematic, which is an opioid, it is now killing people inadvertently. It gives very high highs, but it's also quite lethal. And particularly, if these are drugs that are being mixed and dispensed illegally, they're being dispensed carelessly. And so fentanyl is going to be the sort of leading edge of the killing that opiates are going to cause. But again, there's massive variation. So this is drug overdose deaths in Philadelphia and San Francisco. And you should notice that they're ebbing and flowing at more or less the same times. But Philly has a much bigger problem. And this is important information to have because you then can begin to think about, well, what does San Francisco have, not have? What is it doing? What are Philly's problems and challenges? What are they doing? What's working? What isn't working? Okay, let me pull out of that and do his next piece. And this one's also really terrific. If you want to know more about the opioid crisis, I'm again flying through this at a dizzying rate, but he's really working hard to try to educate the public in a public health interested way. So how bad is it? I'm going to just run through these questions. How bad is it? It's the deadliest drug crisis in American history. Drug overdoses are the leading cause of death for Americans under 50. And deaths are rising faster than ever, primarily because of opioids. Overdoses killed more people last year than guns or car accidents and are doing so at a pace faster than the HIV epidemic at its peak. In 2015, roughly 2% of deaths, 1 in 50 in the United States, were drug-related. We're number one. What is an opioid? I'm not going to go into very much detail at all about this. It actually it's all about brain chemistry, and I mean almost weekly now we are learning more about how the brain works, or doesn't work if you're a teenager. No, but that's actually quite serious. You don't have a frontal lobe when you're a teenager. So is this crisis about prescription painkillers or heroin? It's about both. So prescription drugs that are now being abused, and heroin, particularly black tar heroin, which is sort of cheap, easy to make, easy to transport. And it's the convergence of those two that is the problem. And now then with this sort of third version of a manufactured opioid, fentanyl, which is going to cause more deaths. That is, in the immediate future, the death rate is going to go up, not down. Show me one way the epidemic has changed. Sure, this is Josh Katz. He's a conversational fellow, and so let's see if it'll move on you. So this is rising, and again, this is gorgeous data. You didn't used to be able to get this and look at this and teach with this, and it doesn't want to stay there. So notice at the end that there's actually going to be 2 peaks. And so there's some speculation about this. So these are age cohorts. There are 2 peaks in drug overdose deaths, and so there's different sorts of sociological explanations about this. The first round are people who began on prescription drugs and then shifted to the heroin, and the lower age cohort are going straight to heroin. I mean, there's different explanations for this. Where is the worst of the problem? And again, to pick up on what Marchand Sen was saying, which is that mortality rates are easier to count, and the data now you can disaggregate it, and you can begin to talk about, well, what's happening, what's available in the infrastructure, what sorts of economic structural factors are occurring in places where more and more people are turning to drugs to salve their souls, if you will, to deal with pain. And there is this kind of zone here that is sort of big, though there's also still a fair bit of red in here on a county-by-county basis. And again, notice, you can run your cursor over it and drill down a bit at the level of counties. Why has the problem gotten so much worse in recent years? So there's a number of factors here, really quickly, and it turns out it's quite complicated. So if I think about teaching public health to students and teaching them how to think about causal complexity. Let me minimize this and go to this fellow. So Quinones wrote a book that received national awards. It's a big book, but it's a terrific read. He has a great narrative voice, but he's a journalist, and so it's an account of the epidemic. And one of the things my students and I did, and we're doing it again this semester as we're reading it, is to try to sort of map all of the moving parts, right? Map all of the moving parts. Why is this epidemic happening? And I trust this will overwhelm you. It's tiny, and look at all of the arrows. This is our best effort to convert his 400-page book into a one-table diagram. And that's 2/3 of it, so it keeps going. And so in causal terms, so if you think about the vertical columns, science and medicine, politics and policy, sort of the public and the kind of public's understanding and relationship to these causes, economics and profits, and then Mexico and migration. So a lot of the black tar heroin was coming from Mexico. Why are people turning to drugs? Post-war globalization, deindustrialization, capital mobility. So Wall Street took capital out of parts of the country that had old industrial structures and high labor costs. The other economic actor, of course, is big pharma. And there's a couple of companies in particular. Purdue is one of them. If I come to this side, one of the crucial parts of the explanation is that the FDA fast-tracked a very potent version of a drug, accepting that it was a slow-release version of the painkiller. But it turns out that it's a slow-release version of the painkiller as long as you swallow it whole. But if you lick the casing off the pill, or if you grind it, or if you adulterate it in any way, you now have a very potent, highly addictive drug with a massive high rather than a slow high. So the slow release was the crucial thing. How do you prevent this from becoming highly addictive? And the FDA fast-tracked the approval of this, one would have to say, and made it available. And then in the world of science and medicine, so scientists are not beyond being criticized. And one of the virtues of this fellow's book is that it turns out that there is a letter, a one-paragraph letter by a fellow by the name of Dr. Jick in 1980 in the Journal of the American Medical Association. So, you had to do a lot to actually get an article in JAMA, but you could send in a research note as a letter. This is a one-paragraph letter in which he sort of said, hey, we've been using opioids as painkillers, and we've not been seeing any addiction. That's all he says. And it's a very specific population with no prior history of addiction, and they're being monitored and controlled. So these are hospital patients. They're in hospital. They don't have any control over dosing and anything. And he says, it's fine. We only saw 4 cases and 18,000 of addiction. That one paragraph then got blown up and quoted and cited as a major study. And it propelled what became known as a pain revolution, which was that people with severe pain need help and they need better treatment, which is absolutely right. It's absolutely right. So you had a convergence of what are sometimes really good intentions, that is, let's treat pain better, with an FDA that released a very, I would say, dangerous version of a very powerful painkiller. You have big pharma saying it'll change your life, and going out and pushing this with doctors. You have some doctors who then are unscrupulous and they're just sitting there writing prescriptions. But most doctors are not like that. But many of them are now facing the prospect of a lawsuit if they are suable for having undertreated the pain of their patients. The FDA says these opioids are fine. The Pain Revolution says they're fine. I take my CMEs run by Purdue, and Purdue says they're fine. And so the doctors around the country are prescribing pain meds. Now, what happens when you can't afford to pay for those pain meds? Then you turn to the black tar heroin. Cheaper. And there's a revolution that occurs in how black tar heroin was distributed. It was in small amounts by young, mostly Latinos in the beginning, who would carry the black tar heroin in balloons in their mouth. And so these were not big busts if they were stopped at all, and they stayed out of the big cities. They circulated in the smaller towns, and they would actually deliver. So you'd call them up and they would deliver to your door. So this was entrepreneurialism at its finest. I mean, this was, drugs on delivery. And so you have a convergence of all these factors, some of them really good and appropriate, and some of them clearly more problematic, that began to produce opioid overdose deaths. And so what I mostly, because I don't expect you to be able to read this, what I mostly want you to get a sense of is that we need, and what we're hoping our students are going to learn to do is to tolerate this level of complexity, because some of these big questions, big problems, have complicated kind of causal stories. And why does that matter? Well, then, if we think then about what's the solution to the opioid crisis look like, and we'll be ending more or less on this. If you accept that the opioid epidemic is complicated and there's multiple factors, you have to have a multi-pronged solution. And so you have to go after both the supply, so it's prescription drugs and they're being stolen, or teens are visiting grandma and they're helping themselves to things in the medicine cabinet. This is actually part of the pipeline. And you've got black tar heroin, and now you've got black tar heroin together with lots of other drugs. So dealers are often now, they've got a panoply of options to give somebody who needs to move on, can't continue to get access to prescription pain meds. So you need treatment, but you also need harm reduction. You need to go after the supply, you need to go after the demand. So what this diagram is getting at is, there's 4 distinct tasks that a good, robust solution has to attend to, all of them with subsidiary kind of programs or goals or targets that are at some level tied to a kind of sophisticated understanding of why we have reached the point that we have. And all of that then is something that one hopes that a good public health program will offer. And I'll end there here, and that is that I'm hoping 4 years from now and going forward, 5 years from now, we'll have graduates who are graduates of the HEAL program in public health, and they'll be ready to enter with a fairly sophisticated kind of set of skills into the social network of organizations that have to be involved in public health solutions.